So we've got a couple of lectures for head trauma. This lecture is just going to go over the types of traumatic injuries you can have, and in some of the other lectures we'll look at management of head injuries and some other concepts within head injuries that are useful to know. So a little bit of anatomy. So going from out to in, you have your scalp. Then you've got your skull. And underneath your skull you have your dura mater, which is the outer layer of your meninges, the protective covering for your brain. Beneath the dura mater you have your arachnoid mater, which is the internal layer of the meninges. And then the pia mater is a very thin cover that sits directly on the surface of the brain itself. It's useful to remember these terms because they help when we get into the specifics of where these injuries occur, the language, epidural, subarachnoid, it can help you figure out where the bleeds are occurring. We'll start with scalp injury, and this is the most common head injury you're going to get called to. They can look very dramatic because the scalp is very vascular. They can bleed a lot. Your role is to determine, is this just a superficial scalp injury or is this actually a more severe, head injury? So you're going to explore the wound, and that may mean just pulling it apart a little bit, having a little feel with your fingers, and if it is just a scalp wound, pad and bandage, transport for stitches at the hospital. If it is a little bit deeper though, and it's actually fractured the skull, it can fracture the skull in a couple of ways. You can have probably this one over here on the right, the depressed skull fracture, is the one that you'll most readily be able to identify. Where you'll run your fingers, like you literally, if you're exploring a scalp wound, you run your fingers through it and you'll just feel a big indentation. That's a very, very high indication of a depressed skull fracture. The linear non-displaced, you're not going to be able to pick most likely. They'll find that on an x-ray. Open skull fracture, again, you'll most likely be able to see that. You may even be able to see some brain tissue through it. And then impaled object, you're not going to miss that. Now there is another type of skull fracture, which is the basilar skull fracture. Sometimes called the basal skull fracture. So it's when you have a fracture in the bottom portion of your skull, often involving there's a flat plate that kind of separates your brain from your nasal cavity, and that's the part that will often break. And there are some signs that you can see. So there's the battle sign, which is that bruising pattern behind the ear, and raccoon eyes, which is a big pair of black eyes. If the injury is more than just a scalp injury and involves an actual traumatic brain injury, there are a couple of different types. So we have epidural, which is bleeding between the skull and the dura, so that outer layer of the meninges. Then you have subdural, which is between the dura and the arachnoid. So it's still not directly on the brain, it's bleeding within the middle layer of the meninges. Then you've got subarachnoid, which is between the arachnoid and the pia mater. So now this is blood that actually is on the brain. And then you've got intercerebral, which is bleeding within the big mass of the brain itself. We also have brain contusions, which is just a fancy name for a bruise, concussions, and diffuse axonal injuries. And we're going to go into these in more detail. So why is this even a problem? There's two ways that bleeding in traumatic brain injury can cause problems. One is that blood is directly irritating to brain tissue. It can cause pain, can cause seizures, and the symptoms like neck stiffness that are very common in things like even like meningitis in medical emergencies, and in trauma, having that blood on the brain is going to cause that classic neck stiffness that people complain of. And the other way that it causes problems, we'll cover this in more detail in another lecture, is that the skull is an enclosed vault and it's full and it doesn't have any extra room. So if blood starts to take up space, something else has to go. Initially that'll be your cerebral spinal fluid, then it will be your blood inside your arteries, and eventually your brain will start to get squashed out of your own skull. So epidural hematomas, the first one we went over, between the skull and the dura, typically involves this artery here, which runs up the behind your temple on both sides of your head, called your middle meningeal artery. It's quite a big artery, and unfortunately your temporal skull is the weakest part. God decided to put the biggest artery right under that part. If that artery is ruptured, it will bleed quite profusely. So you can have people who have a big hit, they have an initial loss of consciousness but then wake up again, which is called the lucid interval, and then a gradual decline in consciousness again. You can see down here it causes that mass effect, or it starts to, the mass of the blood starts to have an effect on the brain, mass effect, and starts to squash it. So you'll see things like ipsilateral dilated or fixed pupils, which just ipsilateral means just one-sided. So one pupil will either be sluggish, non-responsive, or fixed and dilated. And other signs of increasing intracranial pressure, leading to unconsciousness and eventually death. Now, subdural hematoma, similar. If you have a look at the picture, again, it can cause a big mass effect. The difference is that it doesn't involve the middle meningeal artery, it's a venous bleed. So you have lots of little bridging veins that go all through the internal parts of your meninges, and this is where those veins have been ruptured. Because it's a venous bleed, it's slower onset. It can be hours, can be days. The level of consciousness varies with the severity of the bleed. But these patients often will have that, if it's occurring over days, they're going to have a slow build-up of symptoms. So headache and slowly worsening focal neurological signs. So, increasing weakness in their hands and legs, for example. Now, alcoholics and any people who are anticoagulated are at a higher risk because they're just at a higher risk of bleeding normally. The intracranial hemorrhage, also exactly the same as a stroke, a non-ischemic stroke, a hemorrhagic stroke, can be arterial or venous depending on which vein or artery has ruptured within the brain. Level of consciousness will fluctuate again, but they're not going to be GCS-15 talking to you. There will be some decrease. Now, because all different parts of your brain are responsible for all different things, depending on where this big bleed is, they're going to have different signs and symptoms. But it will broadly mirror stroke symptoms because this is essentially a hemorrhagic stroke. So you may get, classic symptoms, facial droop, loss of motor or sensory function on one side, things like that. And they'll often have a severe headache with associated vomiting. Now, a subarachnoid hemorrhage, so this is blood actually on the surface of the brain itself. Again, tends to be a venous bleed, so it can be quite slow. And the symptoms are similar to the other types of head injuries. So it will cause that classic, neck stiffness because the blood is irritating to the brain. Can cause vomiting, loss of consciousness. If it's unmanaged and not caught in a reasonable time frame, it can also start to cause a mass effect and raise intracranial pressure, and you'll have symptoms of that. Now, concussion is not a traumatic, it is a traumatic brain injury, but there's no bleeding. So this is where the head takes a very big hit and the brain basically goes crashing onto the inside wall of the skull. Typically causes unconsciousness, and the person will come around and be confused. But crucially returns to normal consciousness and stays there. Doesn't then deteriorate, so there's no lucid interval, and then they go downhill again. They may be confused and not be able to remember what happened, ask the same questions over and over and over. We can't differentiate reliably someone who has a concussion versus someone who has a more serious, bleed. So concussion patients, it should be very routine, even if you think it's just a concussion, to transport these patients to hospital for further observations. Cerebral contusion is a very common side effect of a concussion. So contusion just means bruise, so giving your brain a big bruise. Again, just big impact from your brain as getting punched in the arm would cause a bruise. It can cause swelling of the brain, which can also cause a mass effect. Because if you just have a simple concussion, the brain has to recover from that initial insult, but then there's no actual structural damage to the brain. If you've got a contusion, you've got widespread, very microscopic, microvascular bleeding. So there will be you will have more symptoms and more severe symptoms. So it'll be more likely to be unconscious, and they'll be unconscious for longer, and then have a more profound confusion afterwards. The other type that you can get, the other type of brain injury, is called a diffuse axonal injury, and this is typically seen in car rollovers, where the head has spun so rapidly and the brain has spun on its axis so rapidly that it actually shears down at the direct neuron level, such as in this graphic here. It just causes generalized swelling of the brain, but there's no lesion, there's no big pool of blood that they can actually pull out. It's just enormous, very diffuse damage through the entire brain, and often has very poor outcomes and is very serious.